It's a privilege to present here in front of Sanjay Kulkarni sir, my Mata, Pita and Guru, everyone. Abhijit Joshi sir is here. And it's been really heart-touching that all these people have seen me as a child, and now I get to talk to them about a subject which is very dear and near to me. At the same time, 9 years ago when we came to Baner, Rajesh sir, BMA, welcomed us with open hands. So really thankful to you, sir, for giving us this opportunity. As I said, just to make it lighter, आपण सगळेजण जर पार्टिसिपेट करू शकलो तर जास्त चांगलं होईल म्हणून आय सेड रादर दॅन हॅव्हिंग अ डायरेक्टेड लेक्चर वी कॅन हॅव अ पॅनल डिस्कशन सो आवर हेड अँड डिरेक्टर डॉक्टर मुक्ता मॅम इज हियर आवर हेड अँड डिरेक्टर फॉर IVF डॉक्टर सचिन कुलकर्णी सर प्लीज सर he's come. So one of the most dynamic, like Sanjay sir said, he's a person who travels across the globe, and he's somebody who is. So yesterday morning he came to Umarji Hospital from Mumbai, dropping his daughter off. He went back to Mumbai in the evening, and now he's here. Oh my God. So and all of this he has done from Kolhapur and then Colombo, and then he's come back. So this is his last 3 days. So, when I was thinking, I have Sambhaji sir, our consultant pediatrician, and Dr. Vishesh Dikshit sir. May I please welcome both of them also here. So, when I was thinking what to present in front of this august audience, because when you are talking about your own topic in front of your own people, say obs-gynae or fetal medicine, it's very easy because then you know what to choose and how to go ahead. But when you have a dynamic audience with such an immense expertise in their own fields, it's very difficult to choose a topic. So I thought maybe something which can go closer to multidisciplinary team management. So I said, no, my guru had given me an opportunity to make delivery decisions in uterine transplant case of Asia Pacific. I wouldn't go there. I had so many cases done under guidance of Dr. Abhijit Joshi. I said I wouldn't go there. We have had a privilege and honor, as the introduction said, to do first case of Bharat with our mentor Kulkarni sir, and we did get to innovate many things. One particularly called as intrauterine, intraoperative ultrasound, where we actually put our probe on the uterus, and then we decide when to take an incision and where to take an incision. So like sir's case here, it had this very costly 10 lakh rupees implant, sir. Yeah. And I had a placenta right here. I had to take an incision there without going through this agony of accidentally hurting that 10 lakh rupees implant and also making patient undergo a very different surgery while she had come for a cesarean. So although then there could be interventional radiology, there could be congenital diaphragmatic hernia operated laparoscopically, but there could be fetal surgery, which is twin to twin transfusion. But I thought, what will be there which can actually give us a Vishwarup darshan, and that is how we chose today's case. 38-year-old, married for 24 years, no living issue, diabetic on insulin, obesity. She had genital TB in 2011, for which she took treatment, and she had 3 pregnancy losses at 20 weeks, 16 weeks, and 28 weeks. And then eventually she underwent a lot of fertility treatments, and she developed cancer endometrium, grade 1, stage 1A, and wanted fertility preservation. So Sachin sir, if I may ask you, how would you guide such a patient when she comes to you?
I think fertility preservation in oncology and fertility preservation in non-oncology are two dear and near subjects to me. Though I'm going to speak a bit on this, I would love to speak a bit about the non-oncological indications as well. I think fertility preservation is very much desired in any oncology case. So herein, we would be looking at options of preserving the oocytes or preserving embryos if she's married, or even for that matter, as an emergency situation of ovarian tissue graft preservation.
Right.
Now, I call it an emergency fertility preservation because sometimes the oncologist may not give us a window of 15 or 14 days of stimulation. One is also worried about the ill effects of higher hormonal raised estrogen, how it can affect the prognosis of that cancer in general as well. So ovarian tissue cryopreservation can be a simple method done laparoscopically, will not take beyond 10 minutes, and can have a very good result. It's no more an experimental procedure, an established procedure. And it can offer a natural pregnancy to that couple at a later date when the cancer therapies are over. So somebody like this, a young lady, definitely we should be going for a fertility preservation after making a very shared decision making of these all the options which are available to us in discussing that time.
Oh, great, thank you so much, sir. I know Mangesh sir and Nirvani sir, if they are here, if you could give us your expertise in this, sir.
I agree with sir that sometimes we have to do the fertility preservation in cancer patients. So it depends on the site of the disease. Like in this case, it is a CA endometrium. So it is very important to preserve the uterus as well. In other cases like lymphomas, leukemias, or any other solid tumor, then we are focused on preservation of ovaries, because anyways we are not going to touch the uterus as a part of oncological management. So whenever there is a issue of these organs like uterus and ovaries to be treated in their oncological treatment, then the more issues there. Otherwise, cryopreservation of embryo is the best, if I am not wrong, and then followed by cryopreservation of ovum for non-gynec cancer patients.
Yeah, I think oocyte cryopreservation is also become as good as embryo because we are all gone to vitrification. So the survival rate of the oocytes has gone up to 98 to 99% with kitazoto vitrification technology. So it does make a difference nowadays.
Thank you. Thank you so much, sir. So she did complete her chemotherapy in 2023. Now she's come back to you for stimulation. How would you like to assess her, sir?
Yeah, I think the foremost would be the ovarian reserve testing. So there is a quantitative marker for somebody's fertility and there is a qualitative marker. So what a person? The moment you are 35 to 37, about 50% of the embryos are going to be aneuploid. And beyond 37, you can roughly say about a 5% increase with every year grabbing in. So 38, 39, the chance, like by the age of 42, you would have about 80% embryos to be aneuploid. So this is one discussion, depending on the age, will bring which is young. Yeah. The second would be quantitative. The quantitative marker is anti-Mullerian hormone. It's commonly mistaken that anti-Mullerian hormone is a qualitative marker. No, not at all. Oh. A Heger study, which is done on giving ecosprin for preeclampsia prevention, when they did a secondary analysis of data, AMH of 0.3 and that of 3.2 had the same fecundity rate. So AMH is just a quantitative marker. It's not to be getting anxious. So I'll go by the AMH, antral follicle count of this particular patient, go by her BMI and choose a drug which can get the best eggs and more eggs. The more eggs and the best eggs can only be obtained with recombinant FSH. So it will be not a correct idea to give HMG stimulations and cutting costs here. Give recombinant FSH. It has less acidic isoforms, more biological activity. Always give a recombinant LH or injection of a low dose HCG with it. So that gives an LH. We need FSH, LH both in stimulation. So we go with all that kind of a particular stimulation and get maximum. Again, we need to educate. If we're going for IVF and doing this, we may require 1 or 2 more cycles as well. That is also a possibility. Is that?
So मी जर माझ्या प्रॅक्टिसमध्ये जनरल प्रॅक्टिशनर आहे किंवा ऑब्स्टेट्रिशियन गायनेकोलॉजिस्ट आहे, मी काय काय केलं पाहिजे? AMH करू, अल्ट्रासाउंड करू आणि तुम्हाला पाठवून देऊ?
Yes, AMH.
का अल्ट्रासाउंड तुम्हाला करायला आवडेल?
I would love doing an ultrasound. कारण काय होतं की अँट्रल फॉलिकल काउंट आहे ना, ते तुमच्या मेन्स्ट्रुअल फिजिओलॉजी सायकल प्रमाणे एक्सप्रेस वेगवेगळ्या पद्धतीने होतं. म्हणजे मेन्स्ट्रुअल सायकल इज डिफरंट अँड ओव्हेरियन सायकल इज डिफरंट. IVF मध्ये मला ओव्हेरियन सायकल मध्ये इंटरेस्ट आहे, मेन्स्ट्रुअल सायकल मध्ये नाही. आणि ओव्हेरियन सायकल स्टार्ट्स अबाउट -3 to -7 days. Depending upon the age of the gland. So, AMCHE stimulation generally will start -3, -7 days. If you start stimulation on day 2, you're going to face asynchrony all the time. So, his fine tuning karta, it's always better that upper scan karta.
Thank you, sir. So, it was her first cycle which did not really work out well. She went to somebody else, not to sir at that time, and she had 4 frozen embryos transferred to her in her second cycle. Would you agree to the management?
No, not at all. multiple embryo transfers should not be done. I think it's a typical enterprise IVF attitude, wherein they go just for the want of beta HCG positive, आपण 3 किंवा 4 गर्भ सोडतो, and which is sheer stupidity. We're inviting more troubles and more agony for the patient as they go, because having a triplet.
तू प्रेग्नेंट झाली माझ्यामुळे, मिसकॅरेज झाली तुझ्यामुळे.
So not more than 2 at any point of time,
right.
Preferably one good morphological embryo, and if you've tested it for euploidy, a single euploid embryo transfer is the way ahead.
Oh. And so would AI and neogenetic technology help you here?
Definitely. Genetic technology partially, but AI a lot. कारण काय असतं ना, ब्लास्टोसिस्ट आपण बघतो, पण ब्लास्टोसिस्ट ग्लोब्युल आहे. आपण मायक्रोस्कोपमध्ये ग्लोब्युल बघत नाही, आपण स्फिअर बघत नाही, पण 2D बघतो. So how many cells are there in a blastocyst? And let's say a blastocyst of 80 cells and a blastocyst of 120 cells. Probably they will have a different potential of implantation and doing good. आणि तर मग हे कोण ओळखणार? And AI will do that. So if you have embryos screened by AI from all directions, it will approximately give you the cellularity of a blastocyst. And काही fine tune आहे, diameter of a blastocyst or तुमचा blastocyst zona thickness. All these small things will add up to the value of the morphological assessment. So AI will be a good tool to assess a blastocyst.
थँक्यू सर. मला माहिती आहे नमिता मॅम इथे आहेत, पळवदे सरांना मी मगाशी भेटलो. वॉन्ट ऑफ टाइम आपण याच्यानंतर खरंच विल बी व्हेरी क्युरियस टू हिअर फ्रॉम यू ऑल्सो अँड लर्न फ्रॉम यू हाऊ यू मॅनेज दीज केसेस. सो मुक्ता मॅम, आता माझ्याकडे ट्रिपलेट प्रेग्नन्सी आली आहे. एक एम्ब्रिओ नाही झाला इम्प्लांट, पण बाकी 3 झाले. शी इज ऑलरेडी 10 weeks. व्हॉट वुड यू लाईक टू डू हिअर?
मी तिथे थोडंसं डायव्हर्शन हे करते की ह्या पेशंटला 3 महिने थांबायला सांगायला काहीच हरकत नाही बिफोर कन्सीव्ह. आणि त्या काळात तिची हाय BMI, तिचं इन्सुलिन, तिची लाईफस्टाईल, तिचं न्यूट्रिशन, या सगळ्या गोष्टी मॅनेज जर करता आल्या तर तिचं प्रेग्नन्सी आउटकम चांगलं असतं, या बेबीचं फ्युचर चांगलं असतं आणि तिचं पोस्ट नेटल सुद्धा चांगलं असतं. त्याच्यामुळे लाईफस्टाईल मॅनेजमेंट आणि एक एम देऊन ठेवलेलं वेट आणि ह्या गोष्टी ह्या आपण आपल्या लेवलला नक्कीच पाहू शकतो. आपल्या वर्षानुवर्ष ते कढाणं आपल्याला माहिती असतं, ते लोक येतात आणि जेवढा GPचा किंवा फॅमिली फिजिशियनचा होल्ड असतो तेवढा क्वचितच कुठल्या कन्सल्टंटचा असतो. त्याच्यामुळे ह्या सगळ्या गोष्टींचं जेनेटिक तर आहे, पण एपिजेनेटिक फॅक्टर्स सुद्धा जर आपल्याला समजावता आले तर ह्या सगळ्या गोष्टी कमी होतील. आता ट्युबलेट्स हा काही तिचा दोष नाही आहे, ॲड्रोजेनिक इंजुरी आहे, पण बाकीच्या गोष्टी मात्र आपण नक्की करू शकतो. आता हे ट्रिपलेट आलाय, एज जास्त आहे, ओव्हेरियन कॅन्सर सर्व्हायव्हर आहे, एम्ब्रिओ IVF आहे, तर अशा पेशंट्सना सगळेच ऑब्स्टेट्रिक कॉम्प्लिकेशन्स मेटाबॉलिक जास्त असतात. तिचं ब्लड प्रेशर जास्त होऊ शकतं, तिचं डायबेटीज अजून अनकंट्रोल होऊ शकतं, तिचं BMI वाढू शकतं, तिचं सर्व्हिक्स इनकॉम्पिटंट असू शकतं. 100 लोक सांगतात झोप 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 म्हणून ती व्यायाम घेत नाही. बेडरेस्ट हा कन्सेप्ट आपल्याकडे खूपच मोठा आहे, जो खरोखरच आपल्याला त्याच्याशी झगडायला पाहिजे की थोडंसंही काही झालं की ती पेशंट नॉर्मल हेल्दी प्रेग्नंट वुमन न राहता अशक्त अनहेल्दी वीक मदर होते. मग आता हे ट्रिपलेट आल्यानंतर आम्ही तुमच्याकडे पाठवतो. कारण ट्रिपलेट आम्ही नक्कीच कंटिन्यू नाही करू इच्छिणार.
येस, कारण ट्रिपलेटचं 70%, 30% मिसकॅरेज रिस्क आहे, 70% एक्स्ट्रीम प्रीटर्म बर्थ रिस्क आहे. सो वी ॲडवाइज की आपण रिड्यूस करूया, 3चं 2 केलं आणि तिला सांगितलं पुणे सोडून जाऊ नको, कारण ह्या सगळ्या रिस्क फॅक्टर आहेत. एज पण होतं, डायबिटीज पण होता, ओबेसिटी पण होती. ती शांतपणे ऐकून घेतलं आणि शिर्डीच्या पुढे आष्टा म्हणून गावे तिथे जाऊन राहिली. सो आय कॅन सी खामकर सर, कणकवले सर, देशपांडे सर इथे आहेत.
Try to remove the placenta which was supplying to the baby, the baby who had lost or IUD has been taken place. We cut the cord short and keep it there. Manage and monitor for infections, and if the infection supersedes, then the decision is different. But otherwise, we try to take her till EDD as far as possible, and definitely beyond 28 weeks, because the chances of survival dramatically change. Of course, this baby had so many problems otherwise also.
सो आणि इथे काउन्सिलिंग अगेन जसं खामकर सर म्हणाले खूप महत्वाचं आहे की त्यांना सांगितलं पाहिजे की आपण 28 आठवड्यापर्यंत पोहोचलो तर 90% चान्सेस यू विल गो होम विथ दिस बेबी. अँड दॅट इज व्हेरी इम्पॉर्टंट. प्रसाद बालटे सर जर इथे असतील, संभाजी सर इथे आहेत, आय थिंक देल अग्री. विल कम टू दॅट पोर्शन इन अ मिनिट सर. इथे सगळ्यात मोठी भीती असते सेप्सिसची. सो वी नीड प्रसाद सर, प्रमोद सर आणि त्यांच्या टीमचं हेल्प. की वी नीड टू नो दॅट वी कॅन मॅनेज दीज पेशंट सेफली. दे नीड अँटीबायोटिक्स आणि मग आपल्याला हे पुढे घेऊन जाता येतं. 28 आठवड्याला ती प्रीटर्म लेबरमध्ये गेली आणि मग मी डेक्सामेथासोन ऑर्डर केलं. वाय शुडंट वी ऑर्डर इट बिफोर? बरेचदा असं होतं ना, ट्विन्स आहे, हाय रिस्क प्रेग्नन्सी आहे, 24 आठवड्याला देऊन टाका, 26 आठवड्याला देऊन टाका. वाय शुडंट वी डू दॅट? अँड
ऑटिझम आणि या बाकीचे कॉम्प्लिकेशन जे न्यूरोलॉजिकल आहे ते अदरवाईज आपण असेस करू शकत नाही. यांचं इन्सिडन्स वाढत चाललं आहे असं दिसतंय. दुसरं असं आहे की त्यांचे चान्सेस ऑफ सर्व्हायव्हर आणि विथ डिफॉर्मिटीज ह्या दोन्ही गोष्टी खूप कॉम्प्रोमाइज्ड आहेत. त्याच्यामुळे ज्या गोष्टीचे तोटे आहेत आणि जे फायदे खरंच माहिती नाही आहेत तितके, कारण आपण तितकं जाऊ शकणार आहे की नाही, असे ड्रग्स आपण न वापरलेले चांगले.
I know Jyoti Agarwal ma'am इथे आहेत, बाकी गायनेकोलॉजिस्ट पण इथे दिसत आहेत. वी वुड लव्ह टू लर्न मोर अबाउट दिस फ्रॉम यू आफ्टर द थिंग. पण आम्ही काय केलं, हिचं डिलेड डिलिव्हरी ऑफ ट्विन केली. पहिलं बेबी मिसकॅरेज झालं होतं 24 वीक्सला. सेकंड बेबी आम्ही डिलिव्हर केलं 28 वीक्स 3 डेजला. 32 दिवसांनी आम्ही डिलिव्हरी केली. फॉर्च्युनेटली माझ्या आयर्लंडमधल्या स्टेमध्ये जे गिनीज बुक ऑफ वर्ल्ड रेकॉर्डमध्ये केस आहे की जवळजवळ 70 दिवसांचा डिफरन्स होता दोन्ही बाळांमध्ये, आणि ती बाळ आता 11 वर्षाची आहे. तर ती केस आम्हाला हँडल करायला मिळाली होती. त्यामुळे लकीली वी कुड मॅनेज दिस केस ऑल्सो वेल. आता गंमत अशी झाली की आम्ही ते 1.1 किलोचं बेबी डेक्सामेथासोन योग्य वेळेला देऊन आणि मॅग्नेशियम सल्फेट पण देऊन संभाजी सरांच्या ताब्यात सुपूर्द केलं. आणि आम्ही पेशंटकडे वळलो. पेशंटला रिटेन प्लेसेंटा होता, 1.5 लिटर ती ब्लीड झाली, पोस्टपार्टम सेप्सिसमध्ये गेली. बट थँक्स टू एक्सलंट फिजिशियन्स दे आर हिअर इन द रूम ऑल्सो, वी कुड मॅनेज दिस केस वेल. आणि then we turn towards the baby. So sir, what are the postnatal challenges you are looking at when you look at these?
प्रीटर्म डिलिव्हरी होती आणि बर्थ वेट 1.1 kg. आणि ह्या प्रीटर्म डिलिव्हरीमध्ये आणि हिस्ट्री ऑफ ट्रॉम म्हणजे प्रीमॅच्युअर रप्चर ऑफ मेम्ब्रेन, तर एक पॉसिबल इन्फेक्शन ही एक मेनली एक चॅलेंजिंग गोष्ट होती. दुसरं, ह्या बेबींना युजली RDS म्हणजे इमॅच्युरिटी ऑफ द लंग आणि त्याच्यामुळे ब्रिथिंग इश्यूज हे इनिशियल डेजमध्ये एक सांभाळावं लागतं. आणि येणाऱ्या काळामध्ये इन्फेक्शन, इंट्राव्हेंट्रिक्युलर हेमरेज, फिडिंग इंटॉलरन्स, NEC ड्यू टू द ऑक्सिजन सपोर्ट किंवा मेकॅनिकल व्हेंटिलेशन, त्यामुळे त्यांना रेटिनोपॅथी ऑफ प्रीमॅच्युरिटी, ॲनिमिया, हे सगळे प्रॉब्लेम्स आपल्याला काय नाही अँटिसिपेट करावे लागतात आणि त्यासाठी प्रिपेअर्डनेस असावं लागतं. तर ह्या बेबीला आम्हाला इनिशियल 3 to 7 डेजसाठी इनिशियल मेकॅनिकल व्हेंटिलेशन, नंतर नॉन इन्व्हेसिव्ह व्हेंटिलेशन द्यावं लागलं, पण आणि सर्फॅक्टन थेरपी द्यावी लागली. आफ्टर सर्फॅक्टन थेरपी वी कुड विन ऑफ दिस बेबी फ्रॉम द व्हेंटिलेटर अँड ऑक्सिजन सपोर्ट विथ द अँटीबायोटिक कव्हरेज. आम्ही इनिशियल वीकमध्ये बेबीला फिडिंग एस्टॅब्लिश करू शकलो अलॉंग विथ द टोटल पॅरेंटल न्यूट्रिशन, आणि बेबीचे फीड वाढवू शकलो. जसं अँटीनेटल कोर्स पण खूपच असा काइंड ऑफ रोलर कोस्टर होता, तसाच NICU मध्ये पण बेबीचा का नाही कोर्स खूपच चॅलेंजिंग आणि काइंड ऑफ रोलर कोस्टर होता. आफ्टर एस्टॅब्लिशमेंट ऑफ फीड, बेबी हॅज स्टार्टेड गेनिंग वेट, टॉलरेटिंग द फीड. अराउंड 3rd, 4th वीकमध्ये बेबी हॅज सडनली क्रॅश्ड काइंड ऑफ, सो वी आर सस्पेक्टिंग सेप्सिस. सो वी हॅव इन्व्हेस्टिगेटेड द बेबी. बेबीचे लॅब जे होते त्याच्यामध्ये इन्फ्लेमेटरी मार्कर्स वेअर रेस्ट. So, and baby was not responding to the routine antibiotic therapy. So we investigated more, and we found that baby was COVID, IgM and IgG antibodies positive. So it was a MISC, so multi-inflammatory system syndrome in the children. So we have treated that way. We have started with the IVIG and methylprednisolone steroid therapy, and baby has responded well. And again, we could win off the mechanical ventilation, establish the feed properly, and slowly baby has started gaining the weight. So baby has stayed with us almost for the 77 days, and we could discharge the baby at a weight of 1.9 kg.
सो 77 दिवसांच्या कोर्स नंतर आय नो वी हॅव ओव्हरशूट द टाइम, जस्ट लास्ट स्लाइड अँड स्टॉप. या बाळांना रेस्पिरेटरी चैलेंजेस पण येतात, बाकी प्रॉब्लम्स पण येतात. सो विशेष सर, आप क्या चैलेंजेस यहाँ पे एंटिसिपेट करोगे विथ क्रॉनिक वेंटिलेशन and surgical complications which we should be handling? You have very kindly shared another case, not our case, over here. So if you want to tell us about that.
With prolonged intubation and ventilatory support, these babies usually end up with tracheal stenosis, and it could be usually subglottic tracheal stenosis, and so to avoid that, many times we also go for tracheostomy for babies who require prolonged ventilation. Thankfully, I don't think this baby had any of those issues. Then another thing with the ventilation is very premature babies, they can end up with pneumothorax.
Right.
So suppose the pressures are not right, they can end up with unilateral or bilateral pneumothorax. That has to be picked up early and adequately managed with ICD insertion. Usually they don't require any further procedures. Now this baby, as we remember, she had developed inguinal hernia.
Right.
So inguinal hernia is very common in neonates. And this is a photo of a different baby. But what we follow for inguinal hernia in neonates is we observe the baby till the baby is in NICU, and just before discharge we operate. We do not discharge a neonate with inguinal hernia because we don't know
Very important part.
when it will get stuck and obstructed. In fact, I have had a patient whom we have posted for Thursday, and the baby developed strangulation on Wednesday night. So it can happen anytime. So the dictum is, if you have an neonate with inguinal hernia, you do not discharge without operating.
And there is another hernia I can see over there for a naive gynecologist.
Yeah,
it looks
so
like.
that's a very small umbilical hernia that is evident in this case. This can wait. So we wait till 2 to 3 years, sometimes 4 years of age. Usually it closes off on its
Oh, so
own.
it does not require surgery.
It usually does not require surgery.
Oh.
Very rarely we need to operate on that.
Oh, thank you, sir. And that is how this case was managed. Many thanks for the multidisciplinary team which is here. I can see Nikhil sir, he had actually done retinopathy screening on this baby, and so many babies he has done screenings. Luckily this baby did not require any treatment, if I remember it right. But many his babies, he has done the surgery on them. Maybe for want of time, maybe we'll come back to this later. But this is the true sense multidisciplinary team which BMA has given us an opportunity to be, building as a family. And I'm really thankful, Rajesh sir, for this great initiative. And thanks to all of you for, because we see even doctors of same fraternity fighting all the time. As against that, getting these 200, 300, 400 people together and making them behave as a family. Thank you so much for this. And thank you, BMA.
Thank you.
Thank you, Chinmay sir, Dr. Umarji ma'am and team for enriching us with your experiences.